All right. We are back. We've got 5 short studies, and there's only a few points I promise where I'll rant, and it won't be for long. So this one, isometric back extensor endurance and chronic low back pain in university athletes. So a couple things about this. It is in university athletes, so they're typically a younger demographic, typically healthier, and they wanted to see if back extensor endurance was correlated to that low back pain. And unsurprisingly, it is, because we see it similarly in other areas of the body. Even personally and clinically, I see essentially the same thing with the neck. So if we test out the deep neck flexors, we can use it as a metric to measure their general improvement of the tissue, which usually correlates with a reduction in their symptoms at the time. So really, this study was not a surprise. What they did to measure the back extensor strength was, rather than a plank where you're on the floor with your forearms and you're using your core to resist gravity, you're on a suspended surface like a table where your legs and hips are still touching the table, but your rest of your torso is in open space. So you got to pull and hold your back straight or flat against gravity. And then they timed it out and they really measured, who had back pain, their score, who didn't, their score, and they really found that there was a big difference in that test between the athletes with and without chronic low back pain, where the low back pain test worse. And this is one of those things where they kind of come to the conclusion of, here it is, university athletes with that chronic low back pain exhibit lesser back extensor endurance than those without the back pain. There's a significant association between it and the test hold time, it being low back pain. The implications include using that low back extensor endurance test for chronic low back pain prediction and tracking therapeutic advancements in clinical practice. So about the only thing that I'm going to say on this is just the fact that it isn't a causative thing, like the fact that you are improving your muscle endurance leads to the pain automatically going down. It is through other various mechanisms that it happens. So it's basically a correlative that we use as an audit. What on earth do I mean by that, and why does the specifics matter? Because even the strongest people and the best athletes will still develop low back pain, and it shouldn't just be looked at as the fact that you having improved endurance will eliminate it. It is just something that we use as an audit should we have excessively low endurance, because it could be a chicken and the egg. Is it, I have low endurance, therefore I'm developing the low back pain, or use it as an audit, or because I'm now actively in pain, my body is not wanting to recruit the muscles necessarily as much or as long before the onset of symptoms. Now, here's the reason why typically for most non-specific pain cases, especially with musculoskeletal origin that aren't complicated by other comorbidities, that it can be used as a clinical audit and predictive tool, is because the things and the tasks that you put your body through in order to increase, or that would naturally increase your endurance capacity, will, through various physiological mechanisms, also typically lead to a reduction in pain, because you're dealing with increased tissue robustness, which can help, is a factor, but also because you are going to be actively working with and around the pain, which will have various mechanistic effects on how your brain and body interpret and choose when to send the pain response. So it is kind of the cherry on top that the pain will go away because you're actively working towards improving the tissue's ability. It's not because the tissue's ability is increased. It is, put another way, it's not the destination, it's the journey. The same things that lead you to have increased or improved muscle endurance, this one's in the low back, others can be for the neck. The same things that you do to make those tissues get better on the test are the same things that would naturally lead to a reduction in non-specific musculoskeletal pain. Okay, so I'm being very specific on my verbiage here. And I'm also saying it is correlative because a lot of these mechanisms will overlap, and it is therefore what we can use to test and audit that should correlate and track with your improvement in symptoms, especially in these conditions. Now, moving on. Yes, I'm moving a lot. I've been sitting around a lot today. Effects of aerobic exercise, in addition to core stabilization exercises, on functional capacity, physical performance, and fall risk in geriatric individuals with chronic non-specific low back pain. So, without going into a diatribe on all the various possible mechanistic reasons that movement exercise, core exercise, etc., will improve the geriatric condition, I am simply going to say this. When we looked at this study, they broke out between doing just core exercise and core plus aerobic exercise. I'm sure if you give it 2 seconds thought, you can take a guess as to who had better results. It was the core plus aerobic exercise. And I don't want you to get hung up on, oh, if I want to reduce my low back pain and improve all of these functional parameters, I must therefore do core plus aerobic. No. In a population that is typically under exercised, not necessarily having the proper nutrition all the time, based on my personal experience dealing with some individuals in this population, it should be thought more of any general physical preparedness intervention, which would include an aerobic component, will improve all of these metrics regardless. Put another way, if we try and hit the minimum movement standards, and I say minimum movement standards that the nation has put out for us, you will see an improvement in these parameters. I think it is for adults like 300 moderate moving minutes, moderate activity moving minutes with 2 days a week at least dedicated towards resistance activities. So those are your minimum metrics. And I think if you hit those, you would also automatically improve these, because specific exercise protocols and interventions really shouldn't be something that we have a discussion with when we're talking about health. They should be more of a discussion when we're dealing with a very either a very finicky specific diagnosis, which even then it's really more of an argument that it doesn't matter as much. It probably matters more. Specific exercise matters more when there's a specific goal that requires a nuanced approach to training. Put simply, if I'm just going for health, specificity doesn't really matter as long as I'm hitting resistance, some level of resistance, and some level of aerobic at minimum or above the recommended amounts in a given week. If I am training with a specific goal, like bodybuilding and hypertrophy, I'm going to tweak and become a little bit more specific on how I approach certain resistance lifts and aerobic training. If I want to become a long distance marathoner, don't know why I would, but hey, let's just talk about it. I would change some of the specifics about different exercises. Sprinting, again, change some of the training that I do from a general physical preparedness, and then add in sport-specific drills that would facilitate speed, power, and explosiveness. So the specific side should really be more of an argument for sport specificity and training goal changes, okay? Like if I have 2 patients in front of me, hey, I just want to be healthier overall, general physical preparedness is all we need to discuss. Hey, I want to be a top contender in, point contact taekwondo. Okay, so there's a few other things that we will have to include on top of general physical preparedness for that person. That is really when we need to talk about exercise specific. So if it is just the geriatric population, do general physical preparedness stuff, which would naturally include core work anyway. If you're doing things like squats, deadlifts, if you're doing anything at all, farmers carries, I love those things. You'll naturally get the core trained. You don't have to specify it and pull it out of the weeds. And then, of course, do aerobic exercise, okay? We don't have to be like, I am only a lifter and a lifter. I do nothing but lift, and I'm only a runner. I only run. I'm not going to touch a weight. We have to have some bridging of the gap, okay? Even if it's not your favorite thing in the world, I don't like doing a lot of really, really long form aerobic work. I don't have to, but I know it's net benefit in my health. So I incorporate it anyway either in a way that you enjoy or that doesn't suck as much for you, okay? You need both, all right? So getting back to the study that I already beat with, with a stick until it's dead, when you do more for the population that doesn't do much anyway, you get better results. So replace core stabilization with general physical preparedness exercise. These findings suggest that general physical preparedness exercises are beneficial for chronic non-specific low back pain, but adding aerobic exercise may enhance these positive effects. So get moving. Last three, evaluation of lumbar segmental motion using ultrasound techniques. This one really wanted to look at two things. One, did mobilization actually improve focal segmental motion? And two, could ultrasound be used as a clinical marker to measure it and track it during a patient's progress? I pulled it out for a third reason as well, and that's just to highlight that when we look at research and it says mobilization adjustments, etc., you actually shouldn't just presume or assume who is doing the mobilization and adjusting, because there are a ton of professionals that, despite it being married to the profession of chiropractic, utilize it as a clinical intervention tool. So this one was in the Department of Physical Therapy at Winston-Salem State University, and their students are the ones that received a low back mobilization in various ways. So either CPA, central posterior to anterior, or the left lumbar rotation mobilization, et cetera, et cetera. So they basically then measured the motion at baseline of the segment, and then after intervention, and then they had them touch their toes, bend on back while using the ultrasound to see how much motion there was. They had them rest prone. So they, let things settle, brought it back up, measured them in neutral, bent forward and bent back, and really just compared things. And what they found was kind of interesting. Repeated measurements revealed significant increases in that low back flexion, combined flexion, and extension, and they persisted even following that 5 minutes of prone resting, regardless of the mobilization technique utilized, with significant interactions between segmental motion, sex, and/or bite and risk that were observable. So they really came down to that discussion. Like I said, they wanted to see if the tool utilized could potentially be valid, as well as could they answer potentially mechanistic reasons why mobilizations may be beneficial for certain patient populations. And they found that, at least in a healthy cohort, or relatively healthy cohort of physical therapy students, that at this time, yeah, the ultrasound can be used, and there is, potential mechanistic cause to why people may have an improvement utilizing manual therapy like mobilization. And they thought, and I can concur with the results, future studies should include patients with low back pain. So actually doing the intervention with a screened population that has something that manual therapy could improve, can we figure out maybe who is even more prone to being to getting a benefit from that specific manual therapy? But again, let's see, is there anything else that I missed in this? No, that's pretty much it. Last two, almost done. Prognostic ability of the START back screening tool for disability and pain intensity outcomes in older adults with low back pain seeking chiropractic care. What on earth is that? I'll take a sip and I'll tell you. So whenever we are working with a new patient or tracking progress with a given patient, there are certain outcome assessment tools, OATs, that are utilized to track progress and really figure out how much improvement are they getting as they fill out these researched questionnaires. I could go into a discussion on the difference between researched population data showing that these are legitimately valid, like, don't get me wrong, but also from a nuanced one-on-one, the N of one discussion, where sometimes it may not be as valuable, but that's neither here nor there. What is in front of us is one of these tools known as the START back screening tool. While it is a good OAT, outcome assessment tool, that you can utilize in addition to others, there are others like the Oswestry, the Back-Burn-Muth scales. All of these have different, albeit similar, questionnaires that you will tally up a score, and that score will tell you how much pain and or disability the patient is going through at any given time. And it is in those numbers and metrics that you track the progress. This one, when they actually broke it out and took a look at the older adult population, its validity wasn't so good. So the whole job of the tool the outcome assessment tool, the screening tool, it wasn't a great tool for that population. So we may want to consider using or capping the age of the START tool to, like, hey, it doesn't really work for people over the age of 60. So it's still great, it's still valid, but once you hit 60, we should probably consider a different one, like the oswestry, like the back burn move, that may give us better data to work with that would also trend and track both for records that I would see, so like, oh, the patient is improving, but also if you are using third-party payers or insurance that they would use to say, oh, they are actually improving, versus if they're using the START one as a screening tool, it would just muddy the waters. So that's what they really found. Of the 700 and I'll say 40 participants, the mean age of the sample study was 66, give or take 7 years, and half the participants were female. The tool that we're discussing showed poor discrimination for predicting no improvement in disability and pain intensity. All values were below 0.6, regardless of whether the tool risk subgroups or the tool sum score were used. And basically, the subgroup and sensitivity analysis did not meaningfully improve discrimination. What does it mean? Well, let's go into the conclusion. The START back tool presented limited prognostic ability to predict outcomes of disability and pain intensity in older adults with low back pain in a chiropractic clinical setting. So if an insurance company, if a clinician is using the data from the START to kind of get a measure or lay of the land of like, what am I dealing with? How significant is it? What can we expect as far as the outcomes are? How long might this take? It's not that great of a tool to tell us those things. So it suggests insufficient evidence for that tool to be utilized. Future research should explore reasons behind its inaccuracy and consider potential modifications or alternative tools. So really, more than anything else, this is neat in the sense that the clinical landscape is always changing, and that we are finding that some tools that we used to use may not be as great, and or the vice versa. In other studies, we may find a tool that we weren't using as much may have a niche use that we can now think about and incorporate into our clinical practice. So this just highlights that if you come to us and wait, 1, 2, 3, 4 years, like I had a patient who didn't see me for 5 years, a lot can change that you may love, you may hate, but hey, we have to do the best that we can with the tools at hand that we know about. And when we get data like this, we have to alter and change accordingly so that we adapt and be better for our patients at any given time. So when it comes to my clinic, seeing this, I'm going to make sure that anybody who's getting within that testing range, so it said 66 plus or minus 7 years. So I'm pretty much just going to ballpark it around 60, age 60 for now. It's an easy number for me to think about. I'm going to make sure that they don't get the START tool. In fact, I don't even know if I was using the START tool to begin with. But regardless, you may be thinking, well, how do you not know? My EHR system has a bunch of different ones that get sent out automatically depending on the patient's questionnaires. So I don't necessarily always know ahead of time which patient is going to be screened with which tool. I just know that they're getting screened with a research tool at a given time. So I'm going to double check my records. And if I see that there is the START tool check mark that it could be utilized, I'm going to make sure that that checkbox is clicked off. Now, last one. Adverse events reported across 15 years of multi-center chiropractic student clinical placements in Western Australia. They wanted to see how safe chiropractic was in a student clinical setting across 15 years. Again, very, but let's actually see the details. So, first up, methods. Patients reporting adverse events were identified from an incident register between 2008 and 2003. Details of all incidents were authenticated through the data from patient follow-ups, clinical records, clinical reports, legal and insurer advice, and were graded 1 through 5 based on severity. So we have people sifting through retroactive data. So they went back, data that was reported legally. This wasn't a survey. This wasn't, did you feel bad? This was literally, did they need to seek care, or did they feel they needed to report, or were there medical records that showed that there was an adverse event that happened that needed either management or a record to be generated? So this is not necessarily unbiased. We can always make an argument that there is bias in here, but It is up to snuff, where if you're going to find something, you're likely going to find it based upon what people need to seek out for care should an adverse event happen. So the results and discussion. Chiropractic services were delivered by 921 students, supervised by 44 chiropractors during the 15-year time span in various environmental settings. Among 400 and basically 11,000 clinical encounters, comprising 300 and basically 50,000 treatment sessions for 62,000 unique patients. So a lot. 20 mild grade 1 clinical adverse events were identified. Okay. So let's repeat that. 62,000 patients, 350,000 treatment sessions with 411,000 clinical encounters. Okay. What's the difference? What's the difference between treatment sessions and clinical encounters? Well, looking at it, my hunch is that the clinical encounters included all treatment sessions plus exam sessions. So you had an initial exam, which would be nearly 62,000 exams, which when you add that up to the treatment sessions, gets pretty close to clinical encounters. Plus a few re-exams thrown in there, we easily get to total clinical encounters. Of those, 350 were active treatment sessions, where active would be receiving any form of intervention or treatment, which in this setting most likely included chiropractic manipulative therapy, spinal manipulative therapy, whatever you want to call it. Could also include soft tissue therapy, but a lot of the likely passive things that students are practicing on in these settings. So out of all of those, 20 adverse events were identified, yielding an incident rate of roughly almost 5 per 100,000 treatment or clinical treatment interventions, or 1 out of 20 and a half thousand clinical encounters. Signs and symptoms of adverse events reported were acute or exacerbated low back pain. So the condition that they were seeking care for either got worse, or in the attempt to treat the area, you developed a new symptom. So, hey, I just feel stiff in my back. Do whatever intervention you have. Yeah, now it kind of hurts. Neck pain and mid-back pain and shoulder pain. So basically, either you tried to do your best and you kind of made it worse and it was new, or you took something that already wasn't great and made it slightly worse. The most common presenting complaints among patients reporting an adverse event were pain in 3 spinal regions. Okay. So when we're dealing with chiropractic care, when it is done as it is trained, as it is supervised, as it is taught, the safety profile is significant. I know there's discussions and talk out there that, yes, even if it is so safe, when you're going to have an adverse event, it is catastrophic. I'll push back on that a little bit. I know that there's discussion when it comes to the cervical spine, but insofar as forces, insofar as potential side effects in different various regions, we do have a pretty good understanding of when appropriate interventions can be utilized, when they should be avoided, and a majority of adverse events that do happen, if they're going to happen in a non-pathological person, which is my presumption here, the most common adverse event is going to be a mild increase in pain that is non-pathological. So all it said was that it was an exacerbation of low back pain. Didn't say anything as far as fractures, torn muscles, etc. So the incident rate, extremely low. The safety profile, extremely good. In this case, when there was adverse events, they were all mild, grade 1. There were no grades 2, 3, 4, or 5. And I know there is the social media sensation about cervical artery dissection, vertebral basal artery dissections, and all those things. That can be a discussion for another time that I'd be happy to tackle. But right now, these interventions, when performed by a trained individual who is doing their due diligence and ruling out the few legitimate contraindications that there are to utilize these interventions for these patient groups, the odds are greatly in your favor to, if you're not going to get benefit, the odds are you're not going to really get hurt either. Because again, the incident rate that it is showing here based on this data, 5 per 100,000 or 1 per 20,500 clinical encounters. So I don't know what more to say. Things that we do are generally safe. Not perfect, hence the 20 milds, but generally very safe if you're seeing a quality healthcare practitioner. So that's all I got. Until next week, I look forward to seeing what's going to come across my desk. Thank you for listening so far. Bye-bye.